Thank you very much for this kind introduction. I would like to thank the organizing committee of the Icarus conference for this nice invitation. I want to present you the ideal treatment for in-stent restenosis in the SFA, and this based on an illustrative case. Here are my disclosures. So I want to present you one of my patients, a male patient, 74 years old, in the history PTA and stenting in the left SFA in 2017, and in 2019 already a treatment for the in-stent restenosis in the left SFA with BCP and spot stenting. The patient is still smoking, has some hypertension and hypercholesterolemia, and is presenting again with Rutherford 3 on the left side, severe claudication since a couple of months. So I performed some investigations. A triphasic signal at the left common femoral is measured, an in-stent reocclusion in the left SFA, a monophasic signal in the popliteal and distal vessels. So I present you here some images. You see a quite sharp aortic bifurcation. We performed a crossover procedure, and here you see the occlusion of a part of native SFA and then the in-stent reocclusion at the mid and distal SFA with re-entry, let's say, at the distal to Hunter's Canal, P1, and a good outflow in the below the knee area, as you can see over there, with an acceptable outflow in anterior and peroneal artery. So I performed, as I've mentioned, a crossover procedure, an access on the right common femoral axis with a glide wire 035, a rim catheter of Cook, and we implanted 6 French 45 centimeter destination of Terumo, a sheet in the contralateral common femoral artery. And then I start with an Advantage 018 wire of Terumo, try to drill, to spin into this occlusion and try to stay intraluminally. Definitely in the first part, because I absolutely want to end in the stent lumen and not between the stent and the vessel wall. It was supported by a Navicross 018 support catheter of Terumo, and here you see that with a little loop we were able to enter the stents nicely intraluminally and step by step going through and through this occlusion. And at some parts it was soft, at other parts it was very tight, so a very heterogeneous plaque, but as you can see, quite successful to pass in intraluminal way with a nice intraluminal position distally. Interesting to see, if you look carefully at the angiography, you notice that there is a kind of meniscus sign, and this combined with the smooth passage of my guide wire decided that, and we all know this, that also here in this case, it is a very heterogeneous plaque lesion with a combination of platelet deposition, fibrin deposition, smooth muscle cells, but also an extracellular matrix production, what is present over there, what was reflected by the very tight zone. So a very heterogeneous plaque, and because of this, I decided to do a debulking first, or as a kind of thrombo debulking, a thrombectomy with the Rotarex S catheter, in order to detach the occluding material, in order to aspirate the detached materials, and in order to fragmentate the aspirated material and transport it out of the body. We do this very slow at 1 centimeter a second, and we don't use a distal protection device in this situation and with this device. So here you see the result after 2 passages with the Rotarex thrombectomy system, and you see that we reached already a quite nice result. Nevertheless, there was still some recoil, some residual stenosis, and also more in the proximal part, flow limiting dissection. So based on this, I switched to my definitive treatment, and I considered the debulking and the thrombectomy with the Rotarex as a kind of vessel prep, also important in in-stent restenosis or reocclusion, treatment, but then finally you need to add a definitive treatment. And my preferred definitive treatment in situations like I exposed you here is a relining, creating an endoluminal bypass with the Gore-Viabahn endoprosthesis with propaten bioactive surface. And why is this? Because this is based on our own experiences with the Reline trial, a randomized controlled trial in only in-stent restenosis and reocclusive lesions with a mean lesion length of 17 centimeter, as you can notice there, that we randomized in a one-to-one way. And here you can notice the 2 years outcome results, and 2 year in difficult lesions in stent, 17 centimeter mean length is quite challenging. While you see that even there we reach a primary patency of 58.4% compared to 11% in the POBA only group. And in terms of freedom from TLR, you see that 2 out of 3, even after 2 years in these challenging lesions, are still without reintervention compared to the 23% of the POBA group. And very important to say, this was published in 2015 in the GVT. Well, at this moment, we didn't have a Rotarex or any other thrombectomy or debulking device available. So I'm sure that by adding this treatment or these vessel prep, that we can reach even better results. Here you see the implantation of the Viabahns, one Viabahn 250 millimeter in length and one of 10 centimeter approximately was implanted with a nice overlap of let's say 1 centimeter, and of course with a very efficient vessel sizing in 1-to-1 ratio. Afterwards, extremely important is to post-dilate in order to overcome all the folding problems and also to have a perfect wall appositioning. We did this again with a 6 millimeter balloon, and here you see the final result. I think interesting to see, also without any evidence for distal embolization up to the foot, no problem at all. So the take-home messages, in my opinion, here are: in-stent reocclusions remain challenging situations to access, to pass, to prep, and to treat these kind of lesions. Debulking of a heterogeneous hydrated matrix seems an essential step as a preparing tool. Relining with a physical barrier towards the simulus for new in-stent re-stenosis and hyperplasia formation offers extremely promising results. This was shown in the Reline 24 months data and confirmed in the Reline Max data that were published last year. And the Gore-Viabahn endoprosthesis with propaten bioactive surface is a perfect tool to realize this goal. I thank you for your attention.